So how many of you have ever had a patient or you yourself have suffered from nagging shoulder pain? Most of you. And how many of you have had cases where you feel you tried every treatment method, yet you still just felt stuck? So a few. Well, what if I told you that I had a treatment method for you that has the potential to decrease shoulder pain and increase range of motion in as little as one treatment session? So with that being said, I'm here today to discuss the short-term effects of mobilization with movement, with or without exercise, on pain and range of motion in recreational athletes with subacromial impingement syndrome. So before I get started, I just wanted to take a moment to thank Darrin and April for their continuous help throughout this process and to thank all of you for being here today. So as I was saying, shoulder pain is a common problem across the physically active population. The most common cause of shoulder pain is subacromial impingement syndrome, or SIS. This can be defined as pain or injury relating to the structures within the subacromial space. It accounts for 36% of all shoulder injuries, and despite its frequency, it's a quite complex pathology with altered scapulothoracic rhythm playing a key role in the onset of the pathology. When it comes to the treatment of SIS, although surgery is an option, treatment generally begins conservatively, with the most common form being corticosteroid injections. So research has shown that this can have improvements in pain and function, but these improvements are not maintained well over time. So with injections not always readily at hand, it's important to explore more options. So manual therapy, specifically joint mobilizations, have been proven to be beneficial for patients with SIS. So previous research compared Maitland, Kaltenborn, and mobilization with movement techniques and found that all had the ability to decrease pain and increase range of motion and function, but MWM showed the greatest improvements. Research has also shown that therapeutic exercise can be beneficial in improving function. Additionally, scapular stabilization exercises have yielded the best results, and MWM and exercise worked best when paired together. So manual therapy can include a wide array of treatment methods, but joint mobilizations specifically have been proven beneficial for SIS. The two most common types are Maitland and Kaltenborn, and while both are passive techniques, Maitland focuses on an oscillatory technique, whereas Kaltenborn focuses on a sustained stretch. Another technique that is active in nature is mobilization with movement, and while research is limited thus far, the research so far has shown superior results as compared to other techniques. So as I said, MWM differs from other techniques in that it is an active joint mobilization. So it utilizes a manual application of a sustained glide by the clinician with concurrent movement of the joint by the patient. So it utilizes pre-positioned scapular alignment to ensure that the patient is in proper biomechanical positioning prior to performing the movement. Additionally, this treatment method should always be pain-free, so the clinician should reposition their hands until they can find a pain-free movement. It's theorized that this technique is better at reducing pain and increasing motion due to the active component, which activates the soft tissue mechanoreceptors, causing proprioceptive tissues to be engaged. And then previous studies show immediate decreases in pain and increases in range of motion when utilizing this method, and better results than other joint mobilization techniques. So within the realm of therapeutic exercise, scapular stabilization has been proven to be beneficial and effective in improving kinematics, pain, and disability. In symptomatic SIS patients with dyskinesis, there is a common pattern of decreased activation of the serratus anterior and lower trap, and overactivation of the upper trap, pec major, and pec minor. So Park and Castelline looked at the activation patterns of these muscles during the following exercises, and they also compared utilizing an external load versus not utilizing one, and found that the addition of an external load, such as a TheraBand, resulted in higher muscle recruitment. So as you can see in this chart here, the bolded exercises provided high activation of the serratus anterior and lower trap, with low activation of the upper trap, pec major, and pec minor, creating the optimal balance between these muscles. This indicated that they could be beneficial for SIS patients. So when examining the current gaps in the literature, there is very limited research on the immediate benefits of MWM on pain and range of motion. Within the studies that showed immediate improvements, only 2 of them looked at forward flexion, 2 of them looked at frozen shoulder rather than SIS, and only 2 of them utilized pain rating scales. And out of these studies, none of them looked at the duration in which the effects lasted. And additionally, there's only one study currently pairing MWM with exercise, and while the results were beneficial, there is no further research out there to support these findings. So then when it comes to applying research, specifically randomized control trials to day-to-day practice, there are a few gaps here. The first and most obvious being that there's a lack of flexibility to accommodate for the changing needs of the participant, making it more difficult to incorporate into practical clinical settings. And then additionally, they only tailor to the average athlete rather than to a specific individual and their needs. Therefore, the purpose of this study was to address the effects and duration of MWM alone and with neuromuscular reeducation exercises in patients with SIS on pain and range of motion measures. There were four main aims of this study, the first two focusing on pain reduction, so to determine the effects of a standalone treatment session of MWM on patient-reported pain during the task of an overhead press movement. We hypothesized that there would be a reduction in pain, but we were unable to hypothesize the duration of time in which the treatment effects would last due to a lack of published observations. The second aim was looking at the effects of MWM paired with exercise on patient-reported pain. We again hypothesized there would be a reduction, and that the duration of time the effects lasted would be greater than without exercise. The third and fourth aims focused on GH range of motion, so the third being to determine the duration of a standalone treatment session of MWM on range of motion. We hypothesized that there would be an increase in active shoulder flexion, but again, we were unable to hypothesize the duration of time due to a lack of published observation. And lastly, to determine the effects of MWM paired with exercise on GH range of motion, we again hypothesized there would be an increase and that the effects would be greater than they would last longer than they would be without exercise. So the first dependent variable of this study was active shoulder flexion range of motion. For all measurements, an Acumar digital inclinometer is used. This specific model has an interclass coefficient of 0.90 to 0.98, specifically for measuring flexion, indicating that it's a very reliable tool. Participants were performing active shoulder flexion, and they were positioned standing with their thumb pointed upwards. For all measurements, the inclinometer was placed on the midpoint of the humeral shaft, and participants were instructed to stop just before the point of pain because we were measuring pain-free range of motion. The second dependent variable of this study was patient perceived change measured through the use of a global rate of change scale. So this global rate of change scale has a test, retest, interclass correlation coefficient of 0.90, indicating that it can be very reliable when assessing a patient's perception of how a treatment is working. So prior to each intervention, the participant performed one standing overhead press with a 5-pound dowel. So they were asked to place it on top of their head and press straight upward, mentally noting any feelings of pain. Following the intervention, they then repeated the same movement, but they were asked to rate their change from the treatment with the following statement. So please rate the overall feeling of pain or discomfort in your involved shoulder during a standing overhead press from the time that you began treatment until now. The participants then repeated this 24 hours later to see if any effects carried over. And then when looking at this scale, a 5-point change in either direction will indicate a significant change. So I conducted a single subject design, specifically an ABAC single subjects withdrawal design. So this means that there was a baseline phase A, followed by the first intervention. Baseline phase A was then repeated, and then the second intervention was introduced. Baseline phases consisted of repeated measures of dependent variables over a period of time, and they had to show a stable baseline pattern before beginning the interventions. The intervention phases then consisted of the introduction of the treatment and post-intervention dependent variable measurements. So here's a further breakdown of the data collection timeline, which I'll break down even further in the upcoming slides. But just note that in a perfect world, participants came in for 13 consecutive days. However, some took longer to baseline, so their total amount of time ended up being longer. So phase A, the first baseline phase, consisted of obtaining shoulder range of motion, specifically active shoulder flexion. So an average of 3 measurements was plotted each day, and participants needed 5 consecutive points within 2 standard deviations. So this chart here in that first section is an example of that. This demonstrates their day-to-day variability, and baselining took an unpredictable amount of time, as I previously stated. After obtaining a steady baseline, the first intervention, which was MWM, was introduced. So the patient was positioned standing, performing active shoulder flexion with their thumb pointed upwards. The clinician was standing next to the involved arm, as you can see in these pictures. One hand was pre-positioning the scapula, while the other was stabilizing the GH joint anteriorly. And then a scapular fixation and movement pattern was applied. The parameters for this treatment were 3 by 20 reps with a 30-second rest between sets. Following the first intervention, the following dependent variable measures were taken, so that global rate of change scale, so they performed the standing shoulder press prior to the intervention as well as immediately following. And then range of motion was measured every minute for 30 minutes. So in this example picture here, there would be 30 consecutive data points to indicate the measurement every minute for the 30 minutes. And then we were looking for the duration in which the effects lasted, or for a loss of all gains, which would mean they would fall back down within that 2 standard deviation range, so back to their baseline. So then baseline phase 2 began 24 hours after the first intervention. So there was a 24-hour post-intervention global rate of change scale to see if any effects from the first intervention carried over. And then it mimicked baseline phase 1 exactly, obtaining those range of motion measures again. And again, they had to show a new stable baseline, so 5 consecutive points, in order to move on to the next intervention. So the second intervention phase consisted of MWM paired with the following exercises. So forward flexion with horizontal abduction, SCAPTION with horizontal abduction, elevation plus external rotation, and a serratus punch. The parameters for the stabilization exercises were adapted from Clark and Russell and consisted of 3 sets by 10 repetitions, a tempo of 4-2-2 for eccentric, isometric, and concentric, and this was maintained with use of a metronome speed. And then a rest interval after each set of 60 seconds. Additionally, an external load was applied through the use of a red TheraBand. So for the first exercise, forward flexion with horizontal abduction, the participants were positioned as seen with their back up against the wall with slight knee bend. They were asked to keep their arm, wrist, and hand in neutral through all the exercises here. And then they were asked to forwardly flex to about 100 degrees of flexion. To keep the tension on the TheraBand consistent for all exercises, the starting position width between forearms was measured and divided by 2, and that determined the length of the TheraBand. So for example, if my starting position was 12 inches, we divide that by 2, the TheraBand would then be 6 inches, and that determines the tension. For the SCAPTION with horizontal abduction, the participant was positioned the exact same way, except this time they were now horizontally abducted 30 degrees forward of the frontal plane, and then again we're asked to raise up to 130 degrees of flexion, maintaining tension on the band. For elevation plus external rotation, they now had their elbows flexed to 90. They were standing up off the wall. They then externally rotated to about 30 degrees and forwardly flexed to 90 degrees, maintaining tension the entire time. And then lastly, for the serratus punch, the participant was standing 2 feet away from the clinician who was holding their band. They had their arm flexed forward to 90 with their elbow locked out straight and forearm and wrist in neutral once again. They started with their scapulas retracted and then protracted as if punching forward. The TheraBand tension for this exercise was determined by measuring from where the clinician was holding the band to the palm of the participant's outreached arm and dividing that by 2. So following that intervention, the exact same dependent variables were taken, so the global rate of change with that standing overhead press, and then range of motion was measured again every minute for 30 minutes. And then there was a final follow-up day to obtain that last 24-hour post-intervention Grach scale, and then a final range of motion measurement to see if any effects carried over, and then this concluded data collection for that participant. So the targeted population was recreational athletes with secondary SIS. Contact was made via word of mouth and email, and permission from coaches was obtained for those who were athletes on campus. With Concordia's population at hand, the age of 18 to 35 was utilized, and 4 participants were needed. So in total, 9 participants were recruited. However, 3 were excluded following the clinical observation screening form, which I'll explain further. And then we did have 2 dropouts due to COVID-19. However, this still left us with the 4 participants remaining that were needed. So for inclusion criteria, as I had stated, recreational athletes, this was defined in this study as an individual who participated in athletics at a recreational level, works out 1 to 4 times a week, and does not train for the same activity for more than 8 hours per week. Additionally, they had to be level 5 to 10 on a Tegner activity level scale. They had to fill out the study inclusion form and pass the clinical observation screening form. So participants filled out this study inclusion form. Questions 1 through 5 just look at previous history, so previous shoulder injuries within the last year, shoulder or C-spine surgeries, things like that. They had to answer no to question 1 through 5 to be included. Question 6 looks at if they're cleared to perform physical activity. This had to be yes due to the fact that they were asked to perform exercises. And question 7 looked at if their occupation required them to perform repetitive overhead lifting. This could have been answered either way, but it helped me direct them on what to refrain from in the 24 hours following the intervention. Following completion of the inclusion form, the participants were screened for secondary impingement. So the following cluster of impingement tests has a sensitivity of 0.75 and a specificity of 0.74, indicating that it has effectiveness in ruling in SIS when 3 or more of the tests are positive. So verbal consent was obtained, and participants were then taken through the following special tests. So Hawkins-Kennedy, near sign, empty can sign, painful arc sign, and external rotation resistance. Once 3 or more of these special tests were positive, they were then asked to perform active shoulder flexion with their thumb pointed upwards. If they had pain with that flexion movement, their scapular positioning was visually observed and a scapular fixation and movement pattern was applied. If the pain was gone following this scapular fixation, it could be inferred that they had secondary SIS and could be included in the study. So for data analysis, the effect of the interventions was determined by changes in trend, slope, level, and variability within the data collected in baseline and intervention phases. So when visually inspecting the data, this is an example picture of what it may look like. So section A demonstrates a level or the relative value of the data pattern. Section B represents a trend, so the direction of data line. Section C represents variability or inconsistency of a series of data points. So this is what we're trying to avoid and why we have those baseline phases. And then not pictured is slope, which is just the rate of change in the data. So there are 2 types of data variations. Common cause variation, which is when in an outcome, a certain amount of variation is random, expected, and tolerable. Then there's special cause variation, which states that the outcome is no longer considered satisfactory because variation has exceeded an acceptable limit. This is when variation that is intermittent or not part of the normal process is an amount of error that is considered out of control. So to determine significance, we utilized the 2-band standard deviation method. This estimates trends in a time series design, showing if there are changes from across the baseline and treatment phases that are statistically significant. So baseline data must be stable. That's why we have that minimum of 5 consecutive days in the baseline phases. And then the trend and level is measured across the baseline and treatment phases to determine if significance has taken place. So if your plotted data point score exceeds 2 standard deviations from the mean, we can be 95% certain that our observed intervention effect is not due to chance. So to reiterate my last point, anything that falls within the green on this curve is considered common or normal because it falls within those 2 standard deviations from the mean in both directions. But as soon as you fall outside of that, so into those red areas, the data is now considered significant. When establishing internal validity, this study had baseline measures that were utilized across all phases. Upper and lower control limits determined if variation was due to common cause or special cause, and that was with the 2 standard deviations above and below. Repeated measures of dependent variables were collected over time, utilizing a standardized strategy. Repeated measures over time allowed the individuals to serve as their own control. And continuous assessment throughout the duration of the study provided a foundation for inferring treatment effects and detecting patterns under various conditions. So then how can we apply this data? You cannot determine the success of an intervention from one single subject design. This is because while individualization can be a benefit to research, it makes it harder to generalize the findings. But direct replication can be helpful in this case. So this can be done through consistency of treatment conditions, settings, and patient characteristics. So one successful single subject design, followed by 3 successful replications, eliminates the possibility of the findings being a result of chance. Therefore, by utilizing this information, we can take the theory to perform larger trials. Additionally, significant effects that an intervention has on a single patient cannot prove that it will work for everyone. However, it is not unreasonable to believe that patients with similar demographics can have equally beneficial results. So the clinical takeaway here is that it's based on the strategy utilized or manipulated. So now the fun stuff, the results. So this is the demographics of my 4 participants. So as you can see, the age was about the same with an average of 19. There were exactly 2 males and 2 females. The average height was 5'6", and the average weight was 150 pounds. Additionally, we had 2 right arms and 2 left arms that were looked at, which just so happened to include one of each gender. So there was a good mix of participants overall. So due to the study design, each participant's results will be examined individually. So when looking at this, as a reminder, a 5-point change on a 15-point scale indicates meaningful improvement or deterioration. So data analysis for participants 1, global rate of change, revealed a 5-point improvement from pre-intervention to post-intervention for both interventions. This indicates that the patient subjectively felt their condition had improved. Additionally, while not clinically significant, 24 hours post-intervention, there was still an increase noted by the participant. So the range of motion results for participant 1 are demonstrated below. So when examining this, you can see there was a change from the A1 to the B phase with a 7.9-degree increase that lasted for 4 minutes. From the A2 to the C phase, there was a 14.9-degree increase that lasted for the full 30 minutes. So the global rate of change for participant 2, there was no clinical significance here. However, there was minimal subjective improvements that did occur immediately following both interventions. And then when examining the graph scale 24 hours after the intervention, there was actually a slight decline noted following the MWM plus exercise. So visual analysis of the lasted for 30 minutes. Additionally, this ended up lasting 7 days following the first intervention. So this is an example of how baselining ended up taking longer because she did not fall back down under that standard deviation range until 7 days following the intervention. Additionally, another change was seen from the A2 to the C phase with a 5.1-degree increase that lasted for 30 minutes, and additionally, effects remained 24 hours after. For participant 3, global rate of change, there was no clinical significance found. However, with improvements of 2 and 3 immediately following and 24 hours following, the participants still felt that their condition had slightly improved. So the range of motion results for participant 3 showed more variability throughout the duration of the study. So as you can see, there's several changes in level throughout both intervention phases, and this participant kind of bounced above and below her baseline throughout the entire study here. However, minimally significant improvements did still occur. So from the A1 to the B phase, there was a 5-degree increase that lasted for a total of 5 minutes. However, the longest duration was 2 consecutive minutes. And then from the A2 to the C phase, there was a 5.1-degree increase lasting for a total of 12 minutes, with the longest being 8 consecutive minutes seen right in the beginning there. And then lastly, for participant 4, there was minimal improvement immediately following the MWM. However, all improvement felt was lost 24 hours after the intervention. However, clinically significant changes did occur following the MWM plus exercise with a 6-point change immediately following, with a 5-point change remaining 24 hours later. And then visual analysis for participants 4's range of motion showed a change in level from the A1 to the B phase with a 10.3-degree increase that lasted for 25 minutes. And then from the A2 to the C phase, we see an even more significant change with a 67.7-degree increase that lasted for a total of 30 minutes. And additionally, effects remained 24 hours later. So to summarize all of this data for the 4 participants, a check mark here indicates significance for that participant. So for the global rate of change in the MWM, participant 1 showed significance. Participant 1 and 4 showed significance for MWM plus exercise with the global rate of change scale. And as you can see, all participants showed significance following both interventions for range of motion. So to discuss all of this further, so as a reminder, AIM-1 looked at the duration of the effects of MWM on patient-reported pain. Collectively, there was no clinically significant improvements in patient-perceived pain, and participant 1 showed clinical significance immediately following the treatment. Although not clinically significant, all participants noted improvement immediately following the intervention, and 3 participants reported remaining improvements 24 hours later. AIM-2, looking at the effects of MWM paired with exercise on patient-reported pain. Collectively, again, no clinical significance found, but participant 1 and 4 showed clinical significance immediately following, and participant 4 had significant improvements remaining 24 hours later. Although not clinically significant, all participants improved following the intervention. All but 1 participant had remaining improvements 24 hours later. So the exception to this was participant 2, who had that slight decline 24 hours after the intervention. It's theorized this may have been a result of muscle soreness, central sensitization, or faulty scapular repositioning. To discuss AIM-3, so the duration of the effects of MWM on GH flexion range of motion, there were statistically significant improvements in all participants. The average improvements were 8.4 degrees that lasted for an average duration of 15 minutes. The largest degree of improvement was seen in participant 4 with a 10.3 degree increase, and the longest improvement was seen in participant 2, who had 30 minutes plus those 7 days following. And then discussing AIM-4, so the effects of MWM plus exercise on range of motion. Again, significant improvements in all participants. The average improvement was 23.2 degrees, and the average time was 25.5. The largest degree of improvement was in participant 4, with 67.7 degree increase in flexion. And the longest improvements seen were in participant 2 and participant 4, who lasted for 30 minutes plus 24 hours post-intervention. So when comparing the 2 treatment methods, MWM plus exercise proved to be the superior treatment method. So it had greater improvements in Grach scale outcome measures, more improvement in Grach scale lasting 24 hours post-intervention. It produced greater increases in pain-free GH flexion, and generated improvements lasting for a longer duration of time. The exception to this trend was in participant 2, who actually saw greater improvements following the MWM alone. One theory is that this may have been due to muscle soreness, or it could have been due to the fact that they sat at a smaller starting flexion deficit. So even though they fell back below their baseline, they sat at the higher end of it, indicating they did not have to travel as far then to reach maximum shoulder flexion range of motion. And then all of these results, it's speculated that these results occurred due to the exercises eliciting proper mechanical alignment and dynamic stability, allowing the neuromuscular reeducation needed to correct scapular dysfunction to occur, thus causing improvement in pain-free range of motion. So there were 5 main limitations of this study, the first being that there was limited previous research. Secondly, primary versus secondary impingement, we could not be certain without further diagnostic testing. The actions of participants outside of sessions, such as recreational, work, and sports participation, and their psychological response to pain, as well as their ability to tolerate and remain controlled during exercises. There were 3 more minor limitations, so hand placement and pressure by the clinician, we could not be certain that this was the same for everyone. And then the interpretation of the global rate of change, as well as the honesty, may have varied among participants. So the clinical implications. MWM when alone and paired with neuromuscular reeducation exercises is an effective strategy to decrease pain and increase range of motion short term. The Grach scale may not always be the most suitable tool, and MWM plus exercise is recommended to receive the greatest overall improvement. Variability in the amount of improvements did occur among participants. This may have been due to their ability to tolerate the exercises, the hand placement and force of the clinician, and the speed at which the movements were performed. It's important to keep in mind that this was a single subject design that was tailored to the needs of each participant, and it is not intended to be utilized as a standardized treatment protocol for everyone. So the takeaway here is that you must tailor the protocol to the patient's specific dysfunction and needs. In conclusion, the visual and statistical analysis of the results of this single subject study provided a level of scientific support for the utilization of MWM and neuromuscular reeducation exercises in patients with secondary SIS. And additionally, minimally important differences were observed with the use of a Grach scale, Therefore, these results do not completely rebut its use in assessing patient perceived treatment effectiveness. And then lastly, future research should focus on examining the long-term effects of both treatment protocols, examining the effects of multiple or consistent treatments, the effectiveness of utilizing the MWM and neuromuscular reeducation concepts on other areas of the body and on other upper extremity conditions. And lastly, in the form of randomized control trials so that we can determine how to utilize them to a more generalized population. Does anyone have any questions?
All right, I'll open it up for questions, starting with the committee here. So.
I'll go first if that's okay. First off, can you hear me? Yeah. Good. Okay. First off, Nicole, really great job. You chose a project. I'm just going to take a minute to just kind of praise you a little bit. So you chose a project that is not only complex and novel in its concept, but also in design. And you really proved to, have command over both of those aspects, which is, it's just impressive. And again, you did a really nice job. So I just have a couple of questions just with regard to like clinical application, not with regard to clarity of your project per se, but just as we're trying to take some things away as clinicians. So a couple things. So in your phase C, which was the MWM plus exercise, you had noted that your exercise choices were based on Clark and Russell's previous research. And I was just curious if there were other options, or are those the gold standards? Like what advice would you give to clinicians?
Yeah, so I think
when they're looking to choose their exercises to pair with this mobilization?
Yeah, I think these exercises are a good starting point. But I think obviously just looking at the movements in general, so you need to be able to hold on to that pattern that you've gained with the mobilization. So these exercises may be too complex to start, so maybe utilize the same movements, but have them start on the table where they're more stabilized and then work up from there. So obviously this isn't the only options out there, but just based on the previous research, these had the best muscle activation. So I think just that's the key thing here, is paying attention to the muscle grouping and activation and finding that optimal like pairing of exercises.
Okay, thank you. And then my other question was with regard to your GROC results. So you had mentioned, I was just curious if if you're looking at from more of like a descriptive data perspective, with the GROC measures change in pain, obviously, but did you find that there was any correlation based on the baseline level of pain to begin with the patient? Meaning, did you find that change, the rate of change, if you will, was impacted by the initial level of pain reported by your patient or your participant?
Yeah.
Does that make sense?
We didn't actually look at this, but just from what I remember from the study. So like participant 2, for example, I believe started, even though she had pain, she started with higher range of motion than some. And she was one of the ones that showed less increase on that GROC scale. So I think it also kind of correlates with function. Like if they can almost get their arm all the way overhead, but they have pain, it's not going to affect them as much as someone that gets pain at 90 degrees and notices it when they do everything in their like day-to-day, like their routine every day. So I think there was a correlation. It's not something I directly looked at, but I would agree that there may have been a correlation there as well.
Great. Yeah, I know it's not a number that you crunched by any means. I just was curious, just from your experience, if you found that there was a relationship there. So, all right, that's it. Nice job.
Nicole, very impressed. I will mirror April in terms of her comments. It's a very novel study, and you have a very strong command of this information, and you explain it very well. I gotta turn this down. We got a bad echo in here. How's that? Kind of. Yeah, can you mute yours? You guys hear me? That's better. So you tackled a tough subject, but what I really liked about it was you wanted to take more of a clinical route as opposed to a standardized RCT. You wanted to show that, hey, we treat our patients as individuals when they come in, and we don't always generalize and throw a protocol at people. And you proved it right here by showing, hey, this didn't work across the board, and it works differently for all these individuals. Some people got better gains than others. And then, you know, the follow-up questions are obviously why, how are these individuals different? Can you just take a minute for everyone that may not understand how you read these, let's take this guy, how you read these line charts and how you determined what was significant, what wasn't, and there's a lot going on here. So can you kind of explain this in a little bit more detail for us?
Yeah, so you can see like the two smaller sections, that's their baseline phases. So that's the minimum of 5 consecutive points that show their day-to-day variability. So from this initial one, we went 2 standard deviations above the mean and 2 standard deviations below, and that's what this dotted purple line represents. So that's their initial baseline. So then when looking at the data, so in terms of like changes in level and things like that, you can see that from their last baseline point to their first intervention point, they immediately jumped above that standard deviation line. So that right there means they're already having improvements. And then since they remained above for 25 minutes here, that's how we determined the duration, because then they fell back below that first standard deviation line, indicating they were back within their baseline range. So they had lost everything they were gained. And then same thing occurred over here. So again, there was just an even greater change. So essentially, we were just looking for areas that did not overlap within the baseline. But so overall, I think it just gives us an idea of the time we have following that mobilization intervention to get those results to stick and to stay with whatever treatment form you would like.
Sure. And what about in terms of like, so let's say that you're working with somebody and you make your general increase, you do your exercises, or whatever else you want to do, and then you see that they start going back down. This could also be potentially used as something to bring them back up in that same treatment session. Yep. So this is just something that can be kind of mixed and matched. If it works and you have a measurable outcome that shows that it works, that's pretty powerful for the clinician, and it's pretty obvious here from the individuals that you did it with, it either worked or it didn't. Mm-hmm. And that's kind of the whole MWM philosophy. If you're doing it right, it's going to work immediately. Yeah. So, great job. I don't have any other questions. I will open up the floor to anyone else.
Nicole, I have one more. Just from a clinical, I'm going to piggyback off what Darrin said, just because you did take such a clinical approach to this. So just with MWM, what have you found with regard to like training, or if someone really wanted to incorporate this into their practice, what have you found as far as resources for a clinician to start to try and utilize these tools and techniques?
Yeah, I mean, the treatment itself, there are classes you can take. So in terms of a clinician becoming more familiar with the treatment in general, that would be a good starting point. I mean, it's like any continuing ed, it's not cheap, but if you invest your time into it and truly want to use it, that would be a good start. But additionally, just looking at the research, I mean, I didn't take the class. I had Darrin teach me because he is certified in it. And I like looked at the research, and that's how I learned how to do it. So that's a great starting point as well. And just slowly incorporating it. And like we have mentioned, it's not going to work for everyone. So if you try it once and it doesn't work, don't just give up on it. Like, try it on other people. I think the biggest thing is just practicing it. It's not easy, especially if you're small like me, and I had a few participants that were twice my height. So making sure you get yourself in the best position in order to like properly perform the treatment method. I think those are the biggest like starting points. If that answered your question.
Yes, thank you.
April, they're typically on the cheaper end. It's a weekend course. It's usually about $500.
Yes, Mariah.
So now that you've completed your study, what if any changes would you make to what you did, or how would you make it better if you did it again?
Yeah. I think it's tough because mine was very complex in general. So like there was more things I think I wanted to do, but realistically it wouldn't have made sense. So like it would have been ideal to kind of perform this more than once, because like most treatment methods, doing it once isn't gonna last or like fix their problem. So that's something I would have added if possible, but now obviously future research can kind of look at that. Otherwise, I don't think there's much I would change. Trying to do it during COVID was not ideal because having 13 consecutive days did make it very hard to get people to buy in. But otherwise, honestly, I was pretty happy with what I like did in the time that I had. And I think anything I would add to it was what I discussed with the future research.
Got a question from Mr. Stig here.
Yes.
Of course, right? Not sure if it was asked, but how do you see this type of intervention being applied to higher level of evidence RCT when treatment is so individualized?
Yeah, so I think that's something that needs to be, like, you need to evaluate previous research. So there was one study that tried to do it, but you just have to keep in mind that a limitation will be you don't have that baseline. So the variability of a patient's day-to-day changes in range of motion may affect your results. So I think it can still be done. And like with any randomized control trial, then a limitation of it is going to be that it's specific to a whole group. So it's not going to work for some people because this treatment method it doesn't. It's not going to fix everyone's shoulder pain. So I think it can be done. It's just going to have to be simplified and condensed into a shorter period of time. And it would have to just be, we're providing this scapular fixation pattern for everyone, regardless of what their starting positioning looks like. So it would just have to be simplified in that way.
Yeah, I would agree with you. There's too many variations, right? So that's the problem with a randomized control trial. We're trying to control everything as much as possible, but then when you're working with somebody in the real world, there are thousands of variables that you just can't control and can have an effect on your outcomes. So we gotta just go with what gives us results and what we can measure. So let's see. Jenny, nice work. Nicole, this is an excellent study, very novel and complex. It looked like there may have been a bigger improvement in ROM for your participants following the interventions, but not as much of an improvement in GROC scores, correct?
Yes.
Yes. Any thoughts on these findings?
So I think with any subjective pain rating measure or anything, you're always going to get varied results because it's how the patient themselves perceives their pain. Some patients or athletes, like they push through pain. So even if it is severe pain, they might rate it as a 1, whereas other people might rate that as a 5 or 6. So in terms of them assessing their own change, even though they got changes in the range of motion, they may not be feeling it themselves yet because it was one day. If we consistently did this treatment and over, the course of a week, they started noticing like, wow, my motion's back and things like that, they may then rate those changes a little bit differently because now they are seeing the results versus me statistically and with data seeing it.
Sure. Does that answer things for you, Jenny? We're gonna say yes. she's got her hands full over there.
Yeah, she's fine.
Stick with another question. Do you think there are certain predictors for people who could benefit?
Certain predictors. Can you explain that more?
So if I'm gonna try to paraphrase for him here what I think he's saying. Do you think there are, there it is. Go ahead, chime in.
That's his ear.
So I'm assuming you haven't looked at this, because it wasn't the purpose of your study. But there are certain predictors or not necessarily like risk factors, but things that could factor in to you predicting patients that were more likely to benefit from this intervention.
In terms of like what I saw, I don't necessarily think there was anything that predicted one way or another. I think in terms of like the global rate of change, like I previously said, those that started with more overall flexion range of motion, obviously I knew ahead of time they weren't going to get as big of increases because you're going to hit maximal range of motion. I think it's tough to say if like those that had scapular positioning that was worse off than others, if that plays a role, because again, like this treatment method just may not work and they may not truly have secondary impingement. But I think that could be one thing is obviously the patient that had 90 degrees starting flexion, you could kind of predict that if it worked, they were going to see the greater results. But overall, I didn't really see any other like risk factors or predictive factors.
One other thing that we could take into consideration is the differences between people that have been dealing with this chronically, how long they've been dealing with it, how old they are, how well they recover. Again, it starts snowballing here with everything. So there are a lot of different things. That would need a good follow-up in terms of, with some correlations or some regressions to try to predict those things.
Yeah, length of time of dysfunction would be really interesting to look at.
I agree.
Point.
Jenny says, I think we hit it right on the head. There's a lot of variables that influence the participants' perceptions on a day-to-day basis. Sorry, it's crazy here right now. Any other questions? Hey, she's got a smile on her face. All right.
She's sitting in a closet or something.
Nicole, anything?
So you kind of mentioned this in your limitations that participation in athletics may affect the results of your study.
Yep.
So do you think that overhead athletes would not benefit as much from this, like while they're in season, or how much do you think that would play into that?
So I think if they were like full blown in season, I think they may still get effects, but it's going to be a lot harder to like maintain that. Just like with a lot of chronic pains, like it's hard to fix while you're in season because they're going to be continuing to do those activities that likely caused the problem in the first place. So I do still think it would be beneficial, even if you just have to use it as like a maintenance treatment until you get them out of season. But I do think obviously your overhead athletes would be the ones that benefit the most from this, but they may not see like the biggest improvements throughout their treatment just because of still being active with that. Yes.
So you said when you were doing your inclusion, like their beginning survey, that they could answer yes or no to having a lot of heavy overhead lifting in their day-to-day life. And you said you would educate them. Mm-hmm. So what exactly would you tell them to do or not do, or prefer that they not do?
Yep. So all of my participants, it more pertained to like what they did day to day. None of them had jobs really that required them. But after each intervention, I just asked them like if they were going to go perform an upper body lift day, I asked them to try to avoid that or push back that lift just because we really wanted to just see how the effects carried over without adding that increased like movement or load throughout the 24 hours after. Obviously, in a normal individual, when you're using this as a treatment method, they're going to have to perform their job every day. But just to simplify things for the study, I wanted to take that aspect out at least for that 24 hours after.
And then, so you've done some research into the mobilization with movement. Have you seen any other research with other parts of the body that like another study could then research as opposed to just the shoulder?
Yeah, so there were very limited research in general. I think there may have been one that did the back, but that's a slightly different like type of MWM. Like there's a bunch of variations within the like Mulligan mobilization concepts, but otherwise it was very limited. The one other study that used it did do the shoulder, and I believe it was SIS. It was either SIS or frozen shoulder, but like I said, there's very limited research. So unfortunately, like when looking at other areas of the body, you kind of just have to take like my study and what's out there as a starting point and just start from there.
Stib says, nice work, Nicole. I'm gonna step back here and play devil's advocate. Okay, so you get your first job, you're working clinically, and someone sees you performing this on a patient of yours.
Yep.
And they look at you and they say, what are you doing? You're like, I'm doing some mobilization with movement. And see, look, it got rid of the pain, it increased range of motion. You could expect one of two things said. One of three. Cool, that looks really great. Teach me how to do it. Or somebody could come out and say, well, why would you do that? How long is that really going to last? You know, so what would be your reply to something like that?
Well, I think obviously now that I've done the research, I'd be able to tell them like it's going to at least last in the short term here, and then we can try to add on other treatments and exercises to like prolong the effects. And if they really had questions, like I'd have no problem pulling this up and walking them through it. And just telling them that like it's helping with the like neuromuscular retraining. So yes, it's a mobilization technique, but by it being active, it's helping their brain remember like this is the proper positioning I should be in, and this like during this movement. And that's what's going to help it last longer. And depending on the parameters I'm doing, like in this case, I did 3x20 to focus on endurance. So that also will help with it lasting like longer than just the 5 minutes following the treatment.
Good, great justification. What if they said, well, hey, there's no research on that. There's next to nothing. That's no good.
I mean, there's next to nothing research on modalities and people still
Oh, mic drop right there.
That would be research it, whether formally in this manner or clinically through your own practice.
You're not doing the patient any harm.
Nope.
If anything, you're giving them an increase. You're helping improve their situation. You saw changes in GROC scores, even if they weren't clinically significant by 5 points. They're still moving in the right direction. Yeah. And that means a lot to somebody who's in pain over time. So just to say that something's not clinically significant or not been studied enough, or it's not an RCT, you're comparing apples, oranges, and pears. You really can't do that stuff. Mm-hmm. So I think I hope we continue to move forward and get this published, because we need more stuff like this. Clinicians need to see things like this. Randomized control trials are good, but what these can add to that is, I mean, it can go in both directions. You can find something that works with single subject design and show that it works and then do it on a larger scale, or you can take something on a larger scale and you're going to have people that it works for and it doesn't work for, and then you kind of tweak it down into a single subject design and say, try to figure out why and how and where and when it works, because you can manipulate all that stuff. So they work together well. So you've done a good thing here. It's a really cool study, and this someone will pick this up if you want to publish it. It's very well done. So that's all I got. Anybody else? All right, well. I have, April, do you have any reservations on anything? No, neither.
Not one.
We're not gonna make you sweat or anything like that. You passed, you destroyed this, you did very, very well. I'm extremely proud of the work that you did. And I'll leave the computer on for a little while, and Nicole will be here signing autographs. So, well done.
Thank you.
Nicole, really nice job. Super impressed.
Thank you.
You crushed it. And I'm so glad you got my message this morning about the black coat and the salmon colored shirt. Phew. I was worried.
Congrats,
we were gonna
Nicole.
show up, man.
Thank you, Jen.
Good job.
Thank you.
Very well.
Nicole, I know we said this, I mean, even when you proposed and stuff, but honestly, you have such a knack for taking something super complex like this and describing it in a way that is easy to understand. This isn't an easy study design to get. It's not done often, so we're not familiar with it. And the way you walk us through it is just, it's really good. I'm sure the audience that's there too would echo that, like, it'd be easy to get lost here if it wasn't described as simplistically and like methodically as you do. And you just did a really nice job with that.
If you get sick of AT, she needs to go into teaching.
It's a thought.
All right. I don't have anything else, so I'm going to shut her down here.
Nicole, did you get a picture?
I did not yet.
Let's make sure we get.
Here at the channel, we're dedicated to establish and foster a positive interprofessional environment in which learning can occur regardless of your profession and/or previous training. Please help us spread the word to your healthcare movement colleagues looking to incorporate more evidence-based research application into their own practice. As always, if you liked what you see, please subscribe and join our YouTube channel community, where the #1 goal is improving the lives of those we serve. A big thanks for hanging out with us over this extended time today. We'll see you in the next video.